Okay, everyone is joined, na?
Yes, sir. Yes, sir. We can start.
Krishna, continue.
Cerebellar signs. Dysmetria is present in both right and left side. Finger nose test was done. That is more severe towards the right side. Intentional tremors more prominent in right arm, observed during finger nose test, and when the patient was asked to lift pen. Dysdiadochokinesis present and more prominent on right side. Rebound phenomenon is present in both right and left side. Tremors are seen during finger nose test. Sorry. Lower limb cerebellar signs, rhombus text is negative. Patient was asked to walk with all the safety precautions. Patient walks irregularly on a wide base, has a tendency to fall on the right side, and walks without stability, and takes a turn with small steps in a circle. Patient cannot walk steadily on tandem gait examination. Heel knee test shows irregular movements along the shin on both right and left side. Hello.
Hello.
Hello. Yes, sir.
Hello. Krishna. Lower limb cerebellar sign.
Yeah, sir. Should I repeat them?
Lower limb cerebellar sign.
Okay. A rhombus test is negative. Patient was asked to walk with all the safety precaution. Patient walks irregularly on a wide base, has a tendency to fall on the right side, and walks without stability, and takes a turn with small steps in a circle. So it's a wide base gait. Patient cannot walk steadily on tandem gait examination. Heel knee test shows irregular movements along the shin on both right and left side. Hello.
Okay. Continue.
CVS examination. S1, S2 heard, no murmurs, carotid pulsations bilaterally equal, carotid bruit not heard, no evidence of atrial fibrillation, peripheral pulses are normal. Abdominal RS and skin examination is normal. So should I move on to my final diagnosis? Hello?
Yes.
Hello? 20-year-old patient, male with difficulty walking. Yes, sir. 20-year-old patient, male with difficulty walking, swaying to right side, difficulty in fine motor activity, positive cerebellar signs like dysmetria, dysdiadochokinesis, finger nose test, tandem gait test, and heel to shin test with positive family history without any signs of peripheral neuropathy, infection, intracranial space occupying lesion, vascular abnormalities, is most likely a case of degenerative cerebellar disease.
Hello.
Hello, yes, sir. Hello.
Continue.
So that's it.
No, we didn't hear you fully. Can you repeat the final thing?
Yeah, sir. 20-year-old patient. 20-year-old patient with difficulty walking, swaying to right side, difficulty in fine motor activity, positive cerebellar signs like dysmetria, dysdiadochokinesia, finger nose test, tandem gait test, and heel to shin test with positive family history without any signs of peripheral neuropathy, infection, intracranial space occupying lesion, vascular abnormalities, is most likely a case of degenerative cerebellar disease.
Okay. So you feel it is a degenerative cerebellar disease. So what can it be?
So according to me, it's subacute. It's spinocerebellar ataxia.
You feel it is spinocerebellar ataxia. So
yes,
what things you will get cerebellar ataxia? See, there are actually about 34 or 44 spinocerebellar ataxias. So, but what is spinocerebellar ataxia?
It's progressive ataxia. Sometimes it is associated with symptoms like pyramidal tract abnormalities, peripheral neuropathy, cognitive deficits, or visual problems, including retinitis pigmentosa.
Yes.
And it's a group
Yes.
of wide group
It is-
of 30 subtypes with
Yes.
hello.
So it is autosomal dominant. So it's important.
And it is autosomal dominant. Yes, sir.
Yes, so that is very important, Krishna, that spinocerebellar ataxia is autosomal dominant. So tell me autosomal recessive cerebellar disorders.
Friedreich's
Any
ataxia.
one of recessive cerebellar disorder?
Yes, sir. Friedreich's ataxia,
Hello?
hereditary. Hello.
Yes.
Sir, can you hear me?
Hello.
Hello.
Yes. Yes. Present कर दिया अभी
Friedreich's ataxia.
Krishna, just close the presentation.
Any other?
Yeah, hereditary ataxia.
Issues.
Okay. Just a minute. Hello.
Krishna.
Yes, sir. Autosomal recessive disorders like Friedreich's ataxia, hereditary ataxia with vitamin E deficiency, ataxia telangiectasia,
Vitamin
and
E.
Sir, E.
Ataxia telangiectasia. Yes. Vitamin E deficiency. Okay.
Yes, sir.
And any other disorder associated with vitamin E deficiency where you have ataxia? Apart from vitamin E deficient cerebellar ataxia, vitamin E is also associated with
beta lipoproteinemia, sir.
Yes, right. Beta lipoproteinemia, where you have malabsorption of your fatty acid, ADK. And therefore you have deficiency of vitamin K, and those patients can present with ataxia. Okay, so you feel it is a cerebellar disorder, right?
Yes, sir.
Can you tell me connections of cerebellum?
Okay, sir. Cerebellum has inputs and outputs. Inputs is from the spinal cord, from the cerebrum, from thalamus, from pons, via the olivary nucleus. And outputs is to the spinal cord again, spinocerebellar tracts. The thalamus, from thalamus to from pons to thalamus to the cerebrum, and also from the vestibular nuclei.
Okay. Can you tell me the parts of cerebellum?
Okay. So there are two hemispheres. Yes, sir. There are two hemispheres. There's one vermis, and there is paravermis area, and there is floccular nodular lobe.
Okay. Can you tell me the individual function of each part?
Okay, sir. So floccular nodular lobe is involved with vision correction and head movement. The vermis for trunk.
Oculocephalic movement. Oculocephalic movements and your pursuit movement.
Yes.
Hello. Yes. Okay. Continue. Then. Krishna.
Yes, sir. Just a minute, sir. Then the vermis. The vermis is involved with axial muscles and coordination of axial muscles. And the hemispheres are involved with distal and distal muscle movements, the limbs mainly.
Okay.
Apart from this, it also plays learning. Apart from this, it also plays hello.
Yes.
Yeah, it also plays a function in planning, coordination, and learning, plus balance and posture.
Okay. Can you tell me the fissures of cerebellum?
The fissures. There is a this superior and middle, superior and inferior fissure. I'm not sure, sir. I'm sorry.
Because as per the fissures lobe, you have the anterior lobe, the posterior lobe, and the flocculonodular lobe. The anterior lobe, posterior lobe, there is a horizontal fissure, and there is a posterolateral fissure also between the posterior lobe and the flocculonodular lobe. And apart from the important connections would be, as you said, spinal cord, cerebrum. The main connection is to the vestibular nucleus also, because it gives inputs regarding the balance. And
Yes,
tell
sir.
me the blood supply of cerebellum.
So there are three arteries supplying.
Yes.
Two arteries supplying. I'm so sorry. The three arteries.
Yes.
Superior cerebellar artery, which is a branch near posterior, when posterior cerebral artery is formed. Near that superior cerebellar artery is seen.
Superior cerebral
Then
artery is
there
a
is
branch of basilar artery.
Then yes, sir.
Superior cerebral artery is
Then
a
there is
branch of basilar
posterior.
artery.
Sorry, sir.
Superior cerebral artery is
Hello.
a branch of basilar artery. Then you have ICA and PICA.
Ica
The
and
ICA is
pica.
also artery.
Again, basilar only.
PICA is a branch of, while PICA is a
Pica
branch
is
of
from
vertebral.
Hello.
Vertebral.
So vertebral, yes, and Ica is from the basilar.
Oh, okay. So what investigations you want to do regarding this patient?
So I would like to do HB, CBC, a B12 serum B12 levels, and then I would like to do MRI.
Specific
Sir.
investigation.
I would like to do MRI. Sir. MRI, sir. Hello, MRI.
MRI brain. Okay.
Yeah.
To look for cerebellar degeneration.
Yes, sir.
Okay. Apart from cerebellar degeneration, what degeneration you will get? Any other CNS system there will be degeneration?
So if cognitive deficits, if there are cognitive deficits, yes, sir. Hello.
Hello.
Yeah, sir. If there are cognitive deficits present, we can see cerebral degeneration as well.
No, but your diagnosis is spinal, na? So you in the cerebellum, as well as you will get degeneration spinal cord also. So you will have spinal cord atrophy also, apart from cerebral atrophy. Okay.
Okay. Right, sir. Yes.
So is there what treatment you will give to the patient then?
So first is counseling the patient about the disorder. But before that, I would also like to do a RT-PCR to rule out Friedreich's ataxia, sir.
Okay.
And then I'll counsel the patient about the disorder and tell him that there is no actual cure or for the disease, but we can always give supportive and supportive care for the patient, like physiotherapy, to improve the lifestyle of the patient, and will counsel the parents of the patient as well.
Physiotherapy, occupational therapy, technical counseling, very important.
So your voice is breaking. Hello. Hello.
Hello.
Yeah, so your voice is breaking. Yes, sir.
Hello.
Hello. Yes, sir.
Apart from that, you will do a genetic test to know which type of ataxia it is. Which is the commonest spinocerebellar ataxia in the world?
SCA3.
Also known as Maladon disease.
Yes, sir.
Okay. And commonest in India?
No, I don't know, sir.
It is SCA2. And what CSF, would you do any investigation on CSF?
of CSF.
Ah.
So I don't think there is any necessity over here because it's not an inflammatory disorder or immune disorder to
Okay. Okay.
do
So you won't do
CSF.
any CSF studies in this patient.
I wouldn't like.
Before spine, but the thing is, spinocerebellar ataxia is a last diagnosis you should give to the patient. Hello.
Yes, sir.
Hello. So the
Yes, sir.
first
I
thing
can.
you will have to. So it is a diagnosis of exclusion, spinocerebellar ataxia. So you have to do an MRI. You will have to do a CSF study. In CSF, you have to do your even your routine microscopy, the cytology, VDRL. You will have to do lactate levels also. CSF lactate levels are very high in ataxias, and you will have to rule out all other causes. Apart from that, you have to rule out demyelination also. You have to do CSF
But
IgG
if there
levels,
is
CSF IgG index.
demyelination, sir, if there
Pardon?
is immune mediated demyelination, hello.
Yes.
Sir, if there is inflammatory demyelination, won't that be also seen in MRI if we do MRI?
See, even you can see it on MRI, but a spinocerebellar diagnosis is like a telling the patient that you don't have any cure and you are going to suffer throughout your life. So
Okay, sir.
we have to get all the treatable conditions done, because you can treat multiple sclerosis, you can treat syphilis, you can treat infections, you can treat viral encephalitis, you can have post-infectious or post-viral cerebellitis. So all treatable things you have to do before you tell the patient that you have a spinocerebellar ataxia.
Okay, sir.
Hello.
Yes, sir.
So apart from your MRI, you will do a CSF study. You will do a eye examination, thoroughly eye examination for fundoscopy to look for retinitis pigmentosa, but also you have to do a ocular nystagmography to look for nystagmus, and all the ocular studies. You have to do a VEP, that is, as well as you have to do a BERA also. So all these studies have to be done before you make a diagnosis of spinocerebellar ataxia.
Okay, sir.
Okay, VEP stands for visual evoked potential, and BERA will test your auditory pathway. Okay, so you have to investigate the patient thoroughly before you go in for diagnosis of spinocerebellar ataxia.
Okay, sir.
So, any questions?
I'll just check in the chat box.
Yeah.
If anyone has any questions, please type it, because previous sessions chats are gone. So Viraj had a question. He has difficulty in walk. The patient has difficulty in walking. Then how is the power normal?
You can have a normal power and you can have an imbalance. You can have difficulty in coordination of your lower limb muscles or your truncal muscles also. So coordination, tone are totally slightly different from your power. You can have a good 5x5 power, but you will not be able to walk. The reason is because there is a lack of balance. The vestibular nucleus, the cerebellum, the thalamus, the red nucleus, the olivary nucleus, the reticular formation, and even the extrapyramidal tract. If there is a lesion in that, you will have a normal power, but there will be a problem with the balance, and that coordination, balance, tone, posture, equilibrium, these are different from your pyramidal tracts. The pyramidal tracts definitely are related to your voluntary action and the power, but the extrapyramidal system as well as your cerebellum and your vestibular nucleus are related to the posture of the body. That will be an axial imbalance, or you can have unilateral. If there's a hemispheric lesion, you will have unilateral right upper limb or right or left upper limb in coordination. So the patient can have 5x5 power, but he'll not be able to walk. That is seen even in posterior column lesions also, where you have deficit of position, vibration, and proprioception.
Yes. So can you explain saccades phenomena?
Pardon? Saccades are actually saccades will never be asked to you in MBBS. But if you want to know, you have the vertical saccades, you have the horizontal saccades, and you have the pursuits also. The pursuits are controlled by your flocculonodular lobe, while the saccades are controlled by your vermis. So the vermis will control the saccades. Saccades are quick movements of the eyes. When you look up gaze and suddenly down gaze, so they are rapid movements of the eyes, while pursuit movements are you're following an object. And saccades generally they are impaired in example would be a progressive supranuclear palsy where your vertical saccades are lost.
Okay.
And in
bilateral pontine bleed.
Pardon?
So in pontine bleed, would there be loss of saccades? No. Like doll's eye same as.
No, doll's eye is different. That is a vestibulo-ocular reflex. Doll's eye is totally different. Doll's eye is a test where you turn the head of the patient while the eyes move in the opposite direction. They are totally different. Well, saccades are done voluntarily. Doll's eye are done passively. Saccades are the up-gaze saccades. When you look, you can have a down-gaze saccades also. When you look immediately horizontally towards the right or towards the left, they are saccades.
Okay.
They are rapid eye movement. Both and they are conjugate.
Okay. Okay, thank you, sir.